This episode of the Cognitive Autopsy is produced for educational purposes only. It does not constitute medical advice or legal advice. The clinical and legal information presented is based on publicly available sources and is intended to support physician education and awareness. Laws, standards of care, and clinical guidelines vary by jurisdiction and evolve over time. Consult qualified professionals for advice specific to your circumstances. This is the Cognitive Autopsy from the Chartered Defense. I am Brian, joined as always by Sarah, our legal analyst, and Paul, physician, clinical educator, and our guide through where the medicine meets the courtroom. Today we are looking at one of the most difficult diagnostic challenges in acute care medicine: bacterial meningitis presenting as a viral syndrome, a disease where the classic exam findings physicians are trained to rely on, Koenig and Brudzinski signs, have a sensitivity of approximately 5%, where the complete diagnostic triad appears in fewer than half of confirmed cases, and where every hour of delay in treatment measurably increases the odds of death and permanent disability. We will walk through the clinical reasoning chain, the specific cognitive traps that drive the miss, the legal landscape, including a $27 million verdict, and the one thing you can do differently on your next shift. Paul, before we get into the cases, where does bacterial meningitis sit in your clinical thinking as a hospitalist?
It is something that should be in the back of our minds, but like most high-risk diagnoses, it is not common. The incidence is roughly 1 per 100,000 adults per year. So on any given shift, the odds that the febrile patient with a headache in front of you has bacterial meningitis are extremely low. And most people with a viral prodrome or flu-like symptoms experience a headache as part of that process. So the symptom itself does not differentiate. That tension between how dangerous it is and how rare it is exactly what makes this diagnosis so prone to cognitive error. You know it exists. You know the textbook presentation. But when you are seeing your 8th flu-like patient of the shift, the mental availability of viral syndrome as an explanation is overwhelming.
Let us start with what this looks like in practice. We are drawing on a pattern that appears across multiple litigated cases, and the research is consistent on this point. The initial presentation is remarkably unremarkable. A patient in their mid-30s presents to an outpatient clinic. They have had a day or two of worsening symptoms: headache, dizziness, general malaise, a low-grade fever. They feel awful. They think they have the flu. There is nothing in the initial presentation that screams emergency. No altered mental status, no petechial rash, no hemodynamic instability. Just a person who feels like they are getting sicker, not better.
And that is exactly the point. If this patient walked in confused, febrile to 104 with a stiff neck and a purpuric rash, no one would miss the diagnosis. That patient gets a lumbar puncture and empiric antibiotics before you finish the physical exam. The diagnostic trap only exists because the early presentation is genuinely indistinguishable from the dozens of viral illnesses you see every week. This is not a situation where the diagnosis was sitting there waiting to be found by anyone paying attention. The early presentation of bacterial meningitis is, by the data, extraordinarily difficult to differentiate from common viral illness, and that is important context for everything that follows. We are not here to say this should have been obvious. We are here to ask whether there is anything in the clinical story that might help us identify this patient before a bad outcome.
The Van de Beek study, a landmark 2004 prospective cohort of 696 episodes of community-acquired bacterial meningitis published in the New England Journal of Medicine, established that only 44% of patients presented with the complete classic triad of fever, neck stiffness, and altered mental status. Individual symptoms were more common: headache in 87%, neck stiffness in 83%, fever in 77%. But the triad as a whole was absent in the majority of cases. It is worth noting that this was a single-center cohort of 696 episodes. And while it remains the definitive study on presentation patterns, those numbers reinforce a critical point. These findings are not sensitive enough for us to anchor our diagnostic decisions to them. The absence of the triad should not lower our suspicion.
That is a number worth sitting with. We are trained to look for the triad. We are tested on the triad, and the triad is absent in 56% of confirmed cases. The saving grace, and this is the clinically actionable piece, is that 95% of patients had at least 2 of 4 cardinal symptoms: headache, fever, neck stiffness, or altered mental status. So the diagnostic trigger should not be all 3. It should be any 2.
Paul, let us walk through the specific cognitive steps that lead to the miss. Starting with what happens before the provider even sees the patient.
It starts at triage. The patient tells the triage nurse they have a fever and a headache, and they feel like they have the flu. The nurse documents flu-like symptoms, and that label goes into the chart. And from that moment forward, the treating provider is reading the clinical data through a frame that has already been set. This is something I want to emphasize because it happens across many diagnoses in emergency medicine, and it deserves to be openly discussed. The research on anchoring bias tells us that once an initial hypothesis forms, subsequent findings are interpreted as either supporting it or irrelevant. Findings that should challenge the hypothesis and that should expand the differential get filtered out in some cases. The triage label is the first anchor, and it is one of the most powerful.
And from a legal standpoint, that triage note matters. In litigation, it becomes part of the documentary record. Plaintiff attorneys will use it to establish what information was available at each point in the encounter. In practice, the triage impression tends to favor the plaintiff more often than the defense, particularly when the plaintiff can point to objective information elsewhere in the chart that suggested something beyond a simple flu-like illness. A documented fever, an elevated white count, a noted neck complaint, any of those combined with a flu-like symptoms, triage label, and no further workup becomes a powerful exhibit.
The provider performs their evaluation. They take a history, fever, headache, myalgias, maybe some nausea. They examine the patient. And here is where the research reveals something that should give physicians a moment of pause. Thomas and colleagues, in a 2002 prospective evaluation of 297 adults at a major academic medical center, published in Clinical Infectious Diseases, found that Koenig's sign had a sensitivity of 5% for bacterial meningitis. Brudzinski's sign, also 5%. Even Nuchal rigidity, the most commonly tested meningeal sign, had a sensitivity of only 30%, with a specificity of 68%. The jolt accentuation test, once promoted as having 97% sensitivity based on a small 1991 study, has been substantially downgraded. A 2020 Cochrane review pooled the sensitivity at 65% with very low certainty evidence. And a 2014 study by Nakao and colleagues found sensitivity of just 21%.
So let me put that in clinical terms. You examine this patient, you check for Nuchal rigidity, maybe there is some discomfort, maybe not. You test Koenig and Brudzinski, negative. You may do the jolt test, negative. And you walk away from that exam feeling like you have done your due diligence. You checked for meningitis, the exam was negative, except a negative meningeal exam by the data tells you very little about whether this patient actually has bacterial meningitis. And it'll be clear that these signs do have high specificity. When they are positive, they are clinically useful. A positive Koenig or Brudzinski should raise your suspicion meaningfully, but we may need to reframe how we think about the negative result. When these signs are absent, the negative predictive value is low. A negative meningeal exam should not lower your suspicion. That is a fundamentally different way of thinking about the bedside exam for this diagnosis, and it is supported by the data.
This brings us to a specific clinical moment that recurs across the litigated cases in our research. In one case that resulted in a $27 million jury verdict, the provider ordered an influenza test. It came back negative. The provider diagnosed influenza anyway, prescribed oseltamivir, brand name Tamiflu, and discharged the patient.
This is a moment to reflect on, but I want to be careful before saying the provider did anything wrong in the absence of other objective data. And that is precisely why we are reviewing this case. It is more likely than not that any one of us could find ourselves in the same situation. It is important to note that this is easy to miss. In the height of flu season, we know that early antiviral therapy is beneficial for decreasing viral shedding and symptom duration. So even a negative rapid test does not fully exclude influenza. And here is where the test performance matters. Rapid influenza diagnostic tests generally have a sensitivity of approximately 50 to 70%, with some studies reporting sensitivity as low as 10%, depending on the specimen type and collection technique. The CDC notes that false negatives occur more commonly than false positives, and that sensitivity varies with the timing of specimen collection, ideally within 3 to 4 days of symptom onset, the body site swabbed, and even the technique of the person collecting the sample. Nasopharyngeal specimens have higher yield than nasal or throat swabs. So, a provider looking at a negative rapid flu test during a high prevalence period has a clinically reasonable basis for considering empiric treatment. The test genuinely misses influenza cases. But treating empirically for flu is not the same as closing the differential. You can treat for flu and still ask, what else could this be? And if the answer includes bacterial meningitis, like the reason for this episode, then the workup should consider expanding to reflect that. The other thing to note is that influenza itself can progress to viral meningitis or meningoencephalitis. So even a flu-positive patient with a worsening headache and neck stiffness may need further evaluation. The flu diagnosis does not end the diagnostic thinking. I want to first be clear with our role on this series. We are not here to say something should have been done differently. We are here to ask, is there anything in the story that we might be able to learn from and integrate into our differential going forward to help identify this patient before a bad outcome? Sometimes there may not be anything identifiable, but we should always look and always ask ourselves this question.
From the legal perspective, this is one of the most difficult facts for the defense to manage. The negative test result was documented in the medical record. The diagnosis of influenza was documented despite that negative result. In litigation, the plaintiff's attorneys will present this sequence as premature closure. The provider had disconfirming evidence for their working diagnosis, and they diagnosed it anyway. The defense in this case argued that their care met established standards because the patient did not present with severe head and neck pain frequently associated with meningitis. The jury awarded $27 million. It is worth noting that the defense argument is plausible on its face, but the reality is that good care, even care that may have met the standard, can end in nuclear verdicts. The extent of injury and the age of the patient carry enormous weight with juries. Documentation is key to minimizing exposure, but documentation alone cannot always prevent a plaintiff's verdict when the outcome is catastrophic.
The defense had offered $250,000 pre-trial.
And I want to say something about this that I think matters for the audience. The provider in this case was not described as careless or inattentive. They were a clinician who saw a patient with flu-like symptoms during what was presumably a busy clinical day, made a presumptive diagnosis, and treated accordingly. Every one of us has been in a version of that encounter. The question is not whether any of us would have caught this, so it is whether we have a reliable process for recognizing when to look deeper, even when the presentation does not announce itself.
The patient in that case was discharged. 2 days later, they were diagnosed with bacterial meningitis stemming from a heart valve infection. They had suffered multiple strokes, hearing loss, vertigo, and permanent brain damage. Their cognitive function was permanently impaired. And this is part of the broader teaching point. Whenever we are evaluating a patient for what appears to be a routine viral illness, we should be assessing risk factors for more serious and potentially insidious disease processes. The history, the medication list, prior cardiac conditions, intravenous drug use, immunosuppression. All of those should be part of our clinical frame, not just the presenting symptom complex. What makes this particular case unusual is that the patient appears to have had no obvious risk factors for an underlying valve infection. This was not a patient with a history of intravenous drug use or known valvular disease. And that is part of what makes it so sobering. This is a case where any one of us might have done exactly the same thing. And that would not necessarily have been wrong. The diagnosis was genuinely difficult. And this pattern, discharge, deterioration, delayed diagnosis, repeats across the cases in our research. In a separate case, a patient presented with severe headache, neck stiffness, and an elevated white blood cell count. Despite suspected meningitis, there was a 14-hour delay in intravenous antibiotics. The patient was diagnosed with E. coli meningitis. Their IQ declined from approximately 145 to the range of 85 to 100. Permanent memory loss, inability to work, drive, or leave home unsupervised. That case settled for $5.6 million. In another case, a patient presented with severe headache and shortness of breath. Blood was drawn, and the patient was discharged before the blood culture results returned. Those cultures grew Streptococcus pneumonia. The patient seized hours after discharge, was diagnosed with meningitis at a second hospital, and died 2 weeks later. The jury awarded $1.12 million.
The time to treatment data is what makes these outcomes so clinically frustrating. This is not a disease where delay costs you a few percentage points of recovery. The numbers are steep. Eisen and colleagues published a multinational individual patient data analysis in 2022, 659 patients across Australia, Denmark, and the United Kingdom. Antibiotic delay beyond 2 hours was associated with an adjusted odds ratio of 2.29 for death, meaning mortality roughly doubled. Beyond 3 hours, the odds of neurological impairment increased as well.
And the data becomes more stark with longer delays. A separate analysis by Prules and colleagues found that door to antibiotic time exceeding 6 hours was associated with an adjusted odds ratio of 8.4 for death. Kuster Rasmussen and colleagues estimated that the odds of an unfavorable outcome may increase up to 30% per hour within the first 12 hours. For context, Miner and colleagues found that patients who received antibiotics in the emergency department, at a mean time of 1 hour and 8 minutes, had a mortality rate of 7.9%. Patients who first received antibiotics as inpatients, at a mean of 6 hours, had a mortality rate of 29%.
And that is where I would say, if you have suspicion for bacterial meningitis, I would not delay antibiotics for the reason of getting a clean culture. CSF colony counts decrease after antibiotics are started, but you generally have a window of a few hours where you can still obtain a culture that has utility. So initiate the broad spectrum coverage based on guidelines, vancomycin plus a third generation cephalosporin, with ampicillin added for listeria coverage in patients over 50 or immunocompromised, and obtain the LP as soon as possible after that. Treatment first, then confirmation. So the clock is already running when the patient is sitting in the waiting room. And the most common reason for delay, accounting for 82% of treatment delays in one Danish cohort, is simply that no one suspected meningitis. Not equipment failure, not antibiotic shortages, lack of suspicion. Again, we are not saying that clinicians are doing poorly or that they lack knowledge of meningitis. We are trying to identify subtle symptoms or objective data that might make this diagnosis rise in our differential, because when it does, the evidence supports acting quickly.
Paul, even in cases where meningitis does enter the differential and the team considers a lumbar puncture, the data suggests there is a systematic procedural delay that consumes the treatment window.
The CT before LP reflex, and this is a system-level problem as much as it is an individual decision. Hasbun and colleagues published a study in the New England Journal in 2001, 301 adults with suspected meningitis, and 78% received a CT scan before lumbar puncture. That CT added a mean of 2.3 hours to time to LP. And here's the key finding. Only 5% of those patients had mass effect on imaging. By 2017, a follow-up cohort by Salazar and Hasbun showed the problem had worsened. 89% received CT before LP, and clinicians did not adhere to IDSA guidelines in 60% of cases.
The IDSA guidelines are specific about when CT before LP is indicated. The criteria include immunocompromised status, a history of central nervous system disease, new onset seizures, papilledema, an abnormal level of consciousness, or focal neurologic deficits. For patients who do not have any of these features, the guidelines support proceeding directly to LP without CT. And critically, the guidelines state that if LP will be delayed, whether for CT or any other reason, empiric antibiotics should be started immediately. The evidence supports this approach.
And this is where the system fails, even when individual providers are trying to do the right thing. The provider suspects meningitis, they order a CT, maybe because that is the institutional protocol, maybe because they are concerned about herniation risk, maybe because it is defensive practice. The CT takes time to obtain. The LP happens after the CT, and by the time antibiotics are started, hours have passed. Proof found that the CT to LP to antibiotic sequence was independently associated with a door to antibiotic time exceeding 6 hours, with an odds ratio of 5.6. There is a natural experiment that shows this can be addressed. Glimmacher and colleagues published a Swedish study in 2015. 712 patients. When Swedish national guidelines removed impaired mental status as a contraindication for LP without prior CT, treatment occurred 1.2 hours earlier on average, and mortality dropped from 11.7% to 6.9%. A single guideline change, almost 5 percentage points of mortality reduction. I am not suggesting this should be the standard everywhere. This is something I found myself considering during this reading, and I think it is worth thinking about. The finding makes clinical sense to me. Meningoencephalitis itself can be the cause of altered mental status, not a consequence of a mass lesion or other process we are using the CT to evaluate. So requiring CT for altered mental status in the context of suspected meningitis may be delaying the very treatment those patients need most. But that is a system-level conversation, not an individual practice change. And I recognize there are legitimate safety concerns on both sides.
Sarah, let us step back and look at where bacterial meningitis sits in the overall malpractice landscape.
Meningitis and encephalitis rank fourth in total malpractice payouts among all misdiagnosed diseases. According to the AHRQ and CRICO analysis by Newman-Toker and colleagues published in 2019. That is based on over 11,000 diagnostic error malpractice claims from 2006 to 2015. The total payouts in that database were $34 million for meningitis and encephalitis, despite ranking only 6th or 7th in frequency among diagnostic error claims. What that tells you is that when these cases go to verdict or settlement, the numbers are large, because the injuries are typically severe and permanent.
What do the plaintiff allegations look like across these cases?
The allegation pattern is remarkably consistent. The most common and legally potent allegation is failure to perform a lumbar puncture when the clinical presentation warranted workup. LP is the definitive diagnostic test for bacterial meningitis, and its omission is objectively documentable. It either happened or it did not. Beyond that, the allegations typically include failure to include meningitis on the differential diagnosis, premature closure on a viral or benign diagnosis, delayed antibiotic administration, and premature discharge without adequate safety netting or follow-up for pending results. The causation element is where the time to treatment literature becomes particularly significant. In meningitis litigation, the plaintiff must establish not just that the standard of care was breached, but that earlier diagnosis and treatment would have changed the outcome. The studies we have been discussing, Eisen, Prue, Custer-Rasmussen, provide strong epidemiological evidence linking timing to outcomes. Defense experts have generally had difficulty overcoming this data. In the $5.6 million settlement case, the defense argued that E. coli meningitis has inherently high morbidity regardless of treatment timing. The court rejected this argument in a 25-page order, finding the plaintiff's causation evidence, drawn from large-scale timing studies, scientifically reliable. That order is significant because it effectively established the evidentiary standard for the plaintiff's case on causation.
And I think it is worth noting what the defense does argue, because the arguments are not unreasonable on their face. The defense typically points to the same Van de Beek data, only 44% present with the full triad, and argues that the presentation did not mandate a meningitis workup. They argue that at 1 per 100,000 incidents, the prior probability was genuinely low, and the initial clinical impression was reasonable given population base rates. They may argue organism virulence, that certain pathogens like pneumococcus or E. coli carry high intrinsic mortality, and the outcome may have been the same regardless of timing. These are arguments that a reasonable clinician might make, and they are the usual tools for seeking a summary judgment or getting a case dismissed before trial. If the breach is not the proximate cause or some other factor is more likely than not the cause of the outcome, the case can be dismissed without a jury hearing it. But what is notable in meningitis cases is that these arguments do not seem to work as effectively as they do in other case types. When a negative flu test is in the chart, when neck stiffness was documented, and when the LP was never performed, the argument that the standard of care was met becomes very difficult to sustain before a jury, and the time to treatment data closes the causation gap that the defense needs to survive.
One additional point on the legal dynamics. The Doctors Company, a major physician malpractice insurer, identified meningitis as 5% of all emergency department diagnostic error malpractice claims. For a disease with an incidence of 1 per 100,000, that is a substantial representation in the claims data. And Spider and colleagues, in an otolaryngology-focused analysis of 38 meningitis malpractice cases, found a mean jury award of $2.1 million versus a mean settlement of $1.5 million.
There is one more cognitive pattern in the research that deserves its own discussion. What happens when the diagnostic error is not confined to a single encounter? In a case documented by Crico and MyEC, a 28-year-old presented with ear pain and facial paralysis. Urgent care diagnosed Bell's palsy. ENT was consulted, concurred with the diagnosis, and increased corticosteroids. 5 days later, the patient was found confused at home. UCT was initially read as normal. The radiologist missed mastoid disease. The patient was eventually diagnosed with bacterial meningitis from mastoiditis. The result was permanent brain damage, hemiplegia, and the need for 24-hour care. 3 defense experts, including 2 retained by the defense itself, agreed that the radiologist fell below the standard of care. The case settled for over $1 million.
3 providers, same diagnosis. This is what the cognitive science literature calls diagnosis momentum. Once a diagnostic label is attached, subsequent clinicians accept it and build on it rather than questioning it. Each provider in that sequence believed they were making an independent clinical assessment, but they were all working within the same frame. Urgent care said Bell's palsy, ENT said Bell's palsy, and by the time the patient deteriorated, the anchor had survived 3 separate clinical encounters. I think of this the way aviation thinks about situational awareness. Pilots are trained to constantly reevaluate their understanding of the aircraft's state, to never become 100% committed to a single interpretation of their instruments. We should approach our diagnoses the same way. Always be ready to back up and re-examine. Always consider it a working diagnosis, not a final one, so that you remain appropriately skeptical and continue surveilling for anything that contradicts your hypothesis. Never have complete confidence that you have the diagnosis. Always be looking for the piece of data that does not fit. Beard and colleagues, in a 2023 analysis of 100 adult community-acquired bacterial meningitis cases from Houston, found that 36% of patients had been seen by a medical provider within 2 weeks before their hospitalization. Those were prior visits where the diagnosis was missed. And Hovmand and colleagues found that when another infection was suspected, when a prior provider had already attached a different infectious diagnosis, the odds ratio for treatment delay was at 65.9. That is not a subtle effect. It strongly supports the idea that diagnosis, momentum, and loss of situational awareness are significant contributors to delayed treatment.
From a liability perspective, this pattern creates multi-defendant litigation. Each provider in the chain of care can be named. And the legal question becomes, at what point should the subsequent provider have reconsidered the inherited diagnosis? Return visits with worsening symptoms are a particularly high-risk moment. The failure to perform a diagnostic reassessment to ask whether the working diagnosis still fits the clinical trajectory is exactly the kind of analysis that expert witnesses will dissect.
And the practical teaching point here is about what you do when you are the second or third provider seeing a patient who is not getting better, whether that is in a handoff at shift change, a transfer from another facility, or a patient returning to the ED with the same complaint. The question that protects both the patient and you is, does the current diagnosis explain the current presentation? If the answer is no, or even if the answer is I am not sure, the differential needs to reopen.
Paul, the research identifies several populations where the diagnostic difficulty is amplified. Can you walk us through those?
The populations where meningitis is hardest to diagnose are, predictably, the populations where outcomes are worst. Elderly patients over 65 present with fewer classic features and more confounders. Van de Beek found that patients over 60 were less likely to present with neck stiffness, fever, and headache. A Spanish cohort found neck stiffness in only 62% of patients over 65 versus 84% in younger adults. And there is a critically important pathogen shift in older patients. Listeria monocytogenes, Staphylococcus aureus, and E. coli account for roughly a third of cases in patients over 80. Ampicillin is added to the empiric regimen specifically for Listeria coverage in this population, but the other organisms, particularly S. aureus and gram-negative pathogens, may carry higher intrinsic virulence and contribute to the significantly worse outcomes seen in elderly patients. Immunocompromised patients, as approximately a third of all bacterial meningitis cases per one large Swedish cohort, present with less headache and less neck stiffness. Listeria causes 40% of infections in this group, and partially treated patients create what may be the most dangerous diagnostic scenario of all. If a patient has received any antibiotics before LP, from a prior visit, from urgent care, from a transferred facility, now the CSF profile can shift. Gram stain sensitivity drops to 40 to 60%. Culture sensitivity drops below 50%. And a lymphocyte shift can occur that actively mimics viral meningitis. So the clinical takeaway extends beyond the specific cases we are discussing today. The risk factors for a misleading presentation include age over 65, any immunocompromised state, HIV, transplant, chronic corticosteroids, active malignancy, biologic therapy, and any prior antibiotic exposure. These are the patients where the presentation is least classic and the index of suspicion needs to be highest. And while we are on the subject of immunocompromised patients, this is a brief aside, but it is important. Cryptococcal meningitis is another diagnosis that should be on your radar in this population. Unlike bacterial meningitis, which presents acutely over hours to days, cryptococcal meningitis tends to present subacutely over days to weeks, with headache, confusion, behavioral changes, and sometimes agitation. It is caused by Cryptococcus neoformans, a fungal organism with a predilection for the central nervous system. The risk populations overlap significantly: HIV with low CD4 counts, organ transplant recipients, patients on chronic corticosteroids, patients on DMARDs or biologic therapies failed, particularly TNF-alpha antagonists like infliximab, brand name Remicade, or adalimumab, brand name Humira. The subacute onset is the cognitive trap. It does not match the physician's mental model of meningitis, which is rapid and dramatic. The diagnosis can be made with a cryptococcal antigen lateral flow assay. A rapid point-of-care test with sensitivity approaching 100%. I have seen this one personally. If your patient is on immunosuppressive therapy and presents with unexplained subacute headache and altered mental status, cryptococcal meningitis should be on the differential. We will be doing a full cognitive autopsy episode on this diagnosis in the future.
Sarah, is there a regulatory framework that addresses meningitis-specific diagnostic performance?
There is not, and that gap is worth understanding. No meningitis-specific quality measure exists at the federal, accreditation, or payer level. The Joint Commission has not issued a sentinel event alert for meningitis. CMS tracks sepsis bundle compliance through SEP1, but SEP1 does not require identification of the infectious source. A meningitis patient may trigger the sepsis pathway and receive broad-spectrum antibiotics without ever having meningitis specifically diagnosed through lumbar puncture. IDSA acknowledged this tension in a 2021 position paper on SEP1, explicitly noting that rapidly progressive, life-threatening infections without shock, such as acute meningitis, should not be neglected as the regulatory focus shifts toward sepsis bundles. This may be a consequence of our focus on bundled therapy directed toward objective targets. The bundles capture sepsis broadly, but they may not prompt the source-specific workup that meningitis requires. IDSA argued these conditions are better addressed through targeted clinical education and guidelines rather than blunt regulatory measures. The AHRQ systematic review by Newman-Toker found that 5.7% of all emergency department visits involve diagnostic error, approximately 7.4 million misdiagnoses, and 370,000 serious harms annually. Meningitis and encephalitis ranked 6th or 7th among the top 15 diseases causing serious misdiagnosis-related harms.
And here is the practical concern. If the sepsis bundle fires and broad-spectrum antibiotics happen to cover the meningitis pathogen, the patient may improve without the meningitis ever being formally diagnosed, which sounds like a good outcome until you realize that the patient may be discharged without appropriate duration of therapy, without appropriate imaging for complications, and without the public health reporting that comes with a confirmed meningitis diagnosis. The sepsis pathway can inadvertently mask the meningitis diagnosis, even when the treatment overlaps. And there is a cognitive dimension to this as well. And when a patient improves on the right treatment for the wrong diagnosis, that improvement can function as confirmation bias. The patient is getting better, which confirms the original assessment in the provider's mind and removes the cognitive drive to reconsider what the actual diagnosis is.
Paul, before we get to the action items, there is one statistic in the research that frames everything we have discussed.
Beard and colleagues in their Houston cohort of 100 adult community-acquired bacterial meningitis cases found that 96% of patients had at least one missed opportunity for earlier intervention. 96%, not half, not a majority, essentially all of them. And what that number tells you is that this is not about individual clinicians making individual errors. This is about a diagnostic system that is structurally set up to miss this disease. The clinical signs are insensitive. The presentation mimics the most common illness we encounter. The definitive test is invasive and gets delayed by reflexive imaging. The antibiotics that could preserve neurological function are held until the workup is complete. Every layer of the process introduces delay, and this disease has one of the steepest time to outcome curves in acute care medicine.
Paul, this is the cognitive autopsy, which means we end with one thing you can do differently. What is the lesson from this case?
The one thing, and this is really about awareness, is understanding just how easy it is for this diagnosis to hide behind the presentations we see every day. The exam findings we were trained to rely on are not sensitive enough to rule it out. The symptoms overlap with dozens of viral illnesses, and the disease punishes delay more harshly than most other acute conditions. The awareness of that data, really internalizing it, is what changes our clinical behavior. That is important for every case we review on the cognitive autopsy. Our goal is to remind ourselves to stay vigilant for these diagnoses that are hiding behind the routine diagnoses we make every day. Education and awareness might save a patient's life and decrease our liability exposure. A negative meningeal exam does not exclude meningitis. A negative flu test should lead us to consider expanding the differential, not confirm it. And let me give you the specific actions. First, when the flu test or the COVID test is negative in a febrile patient with headache, that should make us pause and ask ourselves the question. It does not mean we must order an LP on every patient, but it should prompt us to consider what else could explain this presentation. If we decide not to pursue a meningitis workup, we should document our reasoning for that decision and provide explicit return instructions focused on symptoms that suggest developing meningitis. Worsening headache, neck stiffness, confusion, new rash. Second, do not rely on Koenig-Brudzinski or jolt accentuation to rule out meningitis. If those signs are positive, they are helpful. If they are negative, they tell you little. A negative meningeal exam is not a negative meningitis evaluation. Third, if you suspect meningitis enough to order a CT, start empiric antibiotics before the CT, not after. Vancomycin plus a third-generation cephalosporin, ceftriaxone, brand name Rocephin, is the most common choice. And add ampicillin if the patient is over 50 or immunocompromised for listeria coverage. Draw blood cultures first if it does not delay antibiotics. The Swedish data showed that removing barriers to early LP and early antibiotics dropped mortality from 11.7 to 6.9%, reinforcing that in this disease, the time between suspicion and treatment is one of the few variables we actually control, and it meaningfully changes outcomes. Fourth, document your reasoning. If you considered meningitis and decided against LP, write down why. If you did not consider meningitis, understand that the absence of that reasoning in the chart is itself a finding that will be examined in litigation. And sometimes, stopping to write down your reasoning may actually give you the reason to further explore the possibility. Anytime we pause and engage our analytical thinking, rather than moving reflexively to the disposition plan, we potentially re-engage the diagnostic process. Fifth, safety net specifically, not come back if you feel worse. Specifically, return immediately if your headache worsens, if you develop confusion, if your neck becomes stiff, or if you develop a new rash, especially spots that do not blanch when you press on them. And if you have blood cultures pending at the time of discharge, make sure there is a documented plan for who is following up on those results. The broader point, and this is the thing I want you to take to your next shift, is that this is not about being smarter or more careful. It is about recognizing that the diagnostic system for this disease has structural vulnerabilities that exist independently of your clinical skill. The exam fails more often than it succeeds. The presentation mimics everything else. The testing cascade introduces delay. The only reliable protection is a low threshold for the definitive test, the lumbar puncture, and a commitment to starting treatment before the workup is complete when suspicion is meaningful.
Bacterial meningitis ranks fourth in total malpractice payouts among misdiagnosed diseases. Not because physicians do not know what meningitis looks like, but because the version they were trained to recognize does not match the version that actually presents. The classic triad appears in fewer than half of confirmed cases. The bedside exam signs physicians rely on have a sensitivity of 5%, and every hour of delay in treatment measurably increases the odds of death and permanent neurological injury. The cases we discussed today, a $27 million verdict, a $5.6 million settlement, a $1.12 million wrongful death verdict, follow a pattern. A viral diagnosis assigned without confirmatory evidence, an LP that was not performed, a patient discharged without specific return precautions, and deterioration that outpaced the opportunity for intervention. Paul, what is the bottom line?
Every one of us has sent someone home with a presumptive diagnosis of viral syndrome. The question is not whether you have done it. It is what happens the next time the flu test comes back negative, the patient has a headache and a stiff neck, and you are 8 patients deep into a busy shift. That is the moment this episode is about. And the answer is not to order an LP on every patient with a headache. The answer is to recognize when your leading diagnosis has been called into question and the patient still has 2 or more cardinal meningitis symptoms. That is when the LP is warranted. That is when the clock starts, whether you know it or not. It is subtle. It is easy to miss. And sometimes it may be impossible to catch, but that is exactly the reason we are discussing it today. To engage our brains and stay vigilant for the subtle clues that something is not adding up.
This has been The Cognitive Autopsy. Thank you for listening. This episode of The Cognitive Autopsy is produced for educational purposes only. It does not constitute medical advice or legal advice. The clinical and legal information presented is based on publicly available sources and is intended to support physician education and awareness. Laws, standards of care, and clinical guidelines vary by jurisdiction and evolve over time. Consult qualified professionals for advice specific to your circumstances.